Mkabile here today. And my colleague has just started recording the session, if everybody's okay with that. So it will be available afterwards if you'd like to follow up on today's talk. So we're going to be hearing from Dr. Siyabulela Mkabile. He is a clinical psychologist and lecturer in the Department of Psychology at the University of Cape Town. He trained as a clinical psychologist at the University of Western Cape, and he subsequently graduated with his PhD at Stellenbosch University in 2021. He has 11 years of experience as a senior clinical psychologist working in the field of intellectual disabilities. And today he's going to be talking to us about his body of research titled Putting Cultural Difference in Its Place, Barriers to Access to Health Services for Parents of Children with Intellectual Disability in an Urban African Setting. So I'm sure we're all quite interested to hear about this. Dr. Siyabulela, if you'd like to start now.
Okay, good afternoon, colleagues, and thank you so much, Ms. Naidu, for that introduction. My talk today is based on my article that I have published last year, which is titled "Putting Cultural Difference in Its Place," and which has a focus on the barriers to access to health services for parents and children, for parents of children with intellectual disability in an urban setting. So as she indicated, my name is Siyabulela, and I am a clinical psychologist and a lecturer with the Department of Psychology in the University of Cape Town. So, as I have indicated, this is a published article that I've written with Prof. Leslie Swartz that I'm definitely sure we're all familiar with. So my focus, I will be focusing on the background, and I will be focusing as well on the methods, findings, lessons learned, and implications of my findings, as well. So starting with the background, there is a lot of evidence in the literature on ID that highlights lack of services or lack of access to appropriate specialist services for children with intellectual disabilities. That is generally all around the world. And while there is a general knowledge or acknowledgement in the literature that lack of services is one of the reasons for lack of or challenges with accessing for this population, with differentiated access for people in rural areas and the peri-urban settings compared to people in the urban settings. That means that is very worse in those people in rural settings. Where the services are still very scarce or sparse. So the dominant narrative in the literature continues to center cultural incongruence and belief system as the main underlying reasons for access challenges for people with ID. So I will be broadening more around that as to what I mean with the cultural incongruence. There is, of course, less focus on more practical embodied barriers to care for people with ID. So, and there are lots of attitudinal factors that continue to explain some of the reasons for access challenges. But our study shows that other contextual factors are equally important. In our study, we explored difficulties in accessing care, specifically the complex, expensive, and time-consuming traveling routes from home to the place of care that the carers of children with intellectual disability took in our study. So the prevalence studies suggest that ID is more common in low socio and middle income countries than in wealthier countries. I think we all know this. And then largely due to poverty, malnutrition, increased exposure to toxins, and higher rates of interpersonal violence. So although prevalence rates are high in these countries, services are still very sparse. So even if they do exist in some countries, they tend to be very clustered in urban settings. Similarly, even in wealthier countries, rural service users are often disadvantaged. So what do we say about Africa? In Africa, service users from rural areas rely on healthcare services are located in urban settings. Most of these services, or most of the service users, they travel long distances and even days to access the services. So in our review on the services in Africa, we noticed that there were biomedical services, that where biomedical services do exist, parents and caregivers may rely heavily on indigenous like healing and spiritual support. So then instead of them going and for long distances and also searching for biomedical services. So these parents from the review that we did in 2021, they absolutely showed that because of the difficulties to access those services, then they turned to indigenous healing methods and also for spiritual support. Interestingly, many studies from Africa identify belief systems as the barriers to biomedical care in the context of ID than the lack of these services. So this means that like we don't talk about this much. The only thing that we tend to say as researchers from the African context, that it's all about the belief systems. People do not believe in biomedical methods. So that is why like they just use like traditional forms of of healing. So we completely ignore the fact that these services are very scarce in our areas. So some of the things that are brought up as things like superstition and practical versus practical questions of access. And in another study that we published in 2020 as well, we reported that attitudinal factors in service utilization may play a big part in the service utilization. And in this current study, what we show is that there is a, sorry about that. I'm so sorry about that. My phone is connected to my laptop, and then when it starts ringing, and then it's kind of like comes back. Okay. In our review, I was just stating that in Africa, we noticed that the biomedical services are very, okay, I did say that. And then interesting enough, many studies from Africa identify these belief systems and barriers to biomedical care in the context of ID than the lack of these services. So, and I mentioned the study that we did in 2020 that showed more attitudinal factors in the service utilization that are playing a major role. So in the current paper, what we show is that there is enormous influence of the contextual factors that must never be overlooked or taken lightly. And this is what I'm going to show. And then our focus on our study was on equitable access to care services. Equitable health services is an indication of functional health system. And then there are 4 principles to this. There is access, there is spatial regression, and then when we define access, it is defined as the opportunity or means to approach or enter the healthcare facility. And then the spatial segregation is associated with the worst healthcare access. People with intellectual disabilities experience spatial exclusion. That's not just only those with intellectual disability, but those with disabilities in general. There are dimensions of access that have been identified by Gilmore and colleagues in 2002. So I'm going to get into them a little bit because this is very important. The work of Gilmore has been widely quoted, especially by those who are planning to have services or are planning services in any context. So equity in healthcare services in South Africa. We know, most of us South Africans, we know that health inequalities have existed in South Africa for decades. And this is the legacy of colonialism as well as apartheid. And then current South African health system is still based on the Colonial Act of 1897. And it is distinguished by two-tier healthcare system, that is public and also the private healthcare system. So the private healthcare system or sector, we know that is well-funded and that is of better quality. The public healthcare sector is poorly funded, fragmented, variable levels of quality of care, historically affordable only to rich minority, that is the private healthcare system. That's even though health is a basic human right in South Africa. The majority of poor still struggle to access high quality healthcare services. Equity in healthcare services, again, as it continues in South Africa, significant access challenges faced by people with ID have been reported. These they include difficulties with the use of minibus taxis, because most of service users of the public sector in South Africa, they use minibus taxis. They rely on them to take them to the healthcare facilities. And then we know these taxis have a very poor safety record and present major challenges and everything that is involved there. And they are not designed to carry, particularly people with intellectual disabilities as well as people with general disabilities, especially for people with range of impairments like mobility impairments and communication impairments. So against all of this background, we are interested in access issues to care for primary caregivers of children with intellectual disabilities. So with all of this in mind, how are these parents accessing the services that are available to them for their children with intellectual disability? So that was the main thing that we were mostly interested on. So how we went about in doing this, the objective was to explore and understand the ways in which Black African carers of children with intellectual disability accessed care within the formal healthcare system, given the low uptake of these services. So our sampling frame, we sampled about 20 carers, including biological parents and relatives of children with ID, who used specialized services in a hospital. So 6 carers, including biological parents and relatives of children with ID, were not currently using any health services, including ID services for their children. All resided in a low in the socioeconomic setting, Khayelitsha, as I indicated earlier on. So we know Khayelitsha is one of the of the townships in Cape Town. And in Khayelitsha, there are no mental health services for severe to serve the predominantly Black isiXhosa-speaking people population. That was like in the past. And I understand now that there are quite a number of special that are situated in district offices. The nearest public mental health service point is in Mitchell's Plain for people with intellectual disability. The ID services at the Stellenbosch Hospital, only one of the two public specialists ID in the Western Cape, and one of very few nationally and as well in the continent. So the study setting in Mitchell's Plain, where is Mitchell's Plain? Is dominantly, I'm trying to give the context where all of these issues are kind of coming up. Mitchell's Plain, we all know Mitchell's Plain, especially those who have lived in Cape Town for many years. Is a dominant spoken language is Afrikaans and English. And while geographically it's located about 10 kilometers traveling time between Khayelitsha and the Stellenbosch Hospital, it can be up to 41 minutes each way, with the cost of 20 rands to 22 rands when you are taking a public transport for the parents. That's the amount of money that they have been paying for all of these years. And if they are traveling as two, because you must remember that the parent is bringing a child to the service at the hospital. So that price is about double. So the differences in the demographic characteristics between Khayelitsha and the Mitchell's Plain are important for contextualizing some of the access challenges experienced by Khayelitsha carers of children with intellectual disability. So the study design we used about in-depth qualitative interviews with carers of children with ID. So now I'm just going to show a map that shows where are these carers coming from. So the green part, this is Khayelitsha, which is where most of these carers are coming from. And then this is where the hospital is situated. And this is where the service is situated. So as you can see that the traveling for the time for the taxis over about 10.9 kilometers distance, it's about 43 kilometers. And I'm sure people who drive are okay, I do 10 kilometers in less than that time. But it's because of all of the challenges and the routes the taxis take and other difficulties as well. So talking about the findings in discussing access issues, a theme that repeatedly came up in the interviews with carers of children with ID related to challenges in getting to the self-service. So the Stellenbosch Hospital's outpatient specialized ID service was the main service carers of children with ID utilized. So despite this proximity of Khayelitsha to IDS, getting to the service presented major challenges. So as we can hear, one of these quotes here, one of the parents says, I travel by taxi, you see, I take taxi from home and it drops me off at the hospital. So I only take one taxi coming here, but when I go back home, I have to take two taxis, one from here to Mitchell's Plain, and then another taxi drops me at home. So it is a long journey because there is no taxi that goes straight to my area from the hospital. So I have to take it from Mitchell's Plain. We take a taxi at the main gate, and I have to pay for him as well. That is referring to the index client. They say he's too old for him to sit on the lap of the mother. When we get here, he's already hungry, but I pack lunch for him so he can eat while we are attended. So this is just one of the examples of given by many of the participants that it is very difficult to travel with a child with ID who has challenges, and that the mother has to pay for herself and also to pay for the child with ID. And as well, sitting, holding your child on your lap in a taxi is a common occurring, especially if the child is much younger. But for others that are much older, and for the taxi drivers as well, do not allow that, and they want the mother to pay for two because there are two heads in the taxi. So, and then the other theme around the typical behavior of a child with ID, which often includes low tolerance, exacerbated challenges faced by some carers trying to access the hospital. And then this is one of the quotes. Yes, I take 15 minutes from AZ Berman traffic lights to IDS, and it takes me 30 minutes from IDS to Stock Road. This one is walking to the other side. The taxi I get there drops me off. It drops me in front of my home. Normally, my child enjoys the walk, but there are times like Friday. He was difficult. He just refused to walk. He just knelt down and would not get up. I begged him and prodded him until we got there. So this parent takes another route, and which the taxi drops her and the child on AZ Berman. So those who live in Mitchell's Plain and those who work in the study area, so they will know how busy AZ Berman road is. So, and there is Highlands Drive as well that connects AZ Berman. So the walking distance from the robots along Highlands Drive is very busy, and it's a bit long. And if the child presents as well with behavioral challenges, then it's difficult. So this mom talks about the difficult where they did not even get a taxi from AZ Berman to Mitchell's Plain. They had to walk to Stock Road, which is further to the other side of the hospital. So, which is a very long distance by foot. And then the third issue is the cost of transport, which was another major access issue faced by carers. It is difficult to get there because it is expensive, and we have to get off at the bottom, and need to make our way up here. When we go back home, it is far, where we have to get a taxi back to the center, where we get one that takes us home. Even then, there's still a long distance to walk before we get home. So, and then the cost also made things worse by lack of safety and at times ongoing protest action in the area. And then here is another one that reflects that. The hospital is not far from Khayelitsha. It is much easier to use a train. So this parent uses a train, but it is not safe. The train is not safe. That's what she's referring to. The next option is the taxi. They are two and drops us off at the gate. The taxis do not come up taxis do come up for an extra charge. So if you take a taxi from Khayelitsha and then you want at least to request the taxi driver to take you closer to the gate, then you have to pay extra charge. So, and this is what she is referring to. And then these challenges, especially the issue of safety, led to some carers deciding not to take their children to the biomedical services that they need or they needed. So I didn't want I didn't want her, referring to the child, to go to the hospital because she was safe when she is here at home than outside. I did not want her to be exposed to the outside world because people would take advantage of her. I don't want her to wait for the taxi a long time because some people can take advantage of her. So, and this parent decided that like, okay, she's gonna keep the child at home because of all of the safety reasons and as well the difficulties to trust the taxi drivers. So others ended up opting for private transport, even though they could hardly afford this, but did so because they wanted their children to access ID services, that is biomedical services. And then the quote there, I use the Red Cross, which is a specialized transport service for her. And I always get good service. I have never been turned away. Yes, if you do not have your own transport, it is far. You need to use public transport. You need to use public transport. You need to go pay for the two of you. So those who can afford like the private transport or the transport by Red Cross, so then you can use that. So the challenges as well of getting child with ID to the service looks toll on both parents and their children. And the caregivers used various culturally informed methods to deal with the stress. And then this parent indicates that I was stressed trying to get my child to the hospital. I had to pray over my child and even cast out the spirits until he calmed down and walked on his own. And although like many of the experiences were difficult, some caregivers also met the unexpected kindness and support when their children exhibited difficult behaviors because of the stress of getting to and from the service. And then this parent indicates that while my child with ID who had behavioral challenges was being difficult, a bus driver stopped and asked what the matter was, and he mentioned that he has a brother who has a condition like my child. So he said, he would have driven us home with his car had he been going to the same direction. So, and this is talking about like people in the streets, like who understand the child with or the difficulty of a parent who has a child with ID, where like you would get what we refer as Ubuntu, and then the person just stops and tries to help or understand what the situation is. Because most of these parents or carers, they also face quite a lot of difficulties and stigma as well in their communities. So that is why for them it becomes so important that someone like a bus driver just stops and asks, what is the matter with you? How can I help? So I think some of the lessons and the implications that we have learned in this paper is that close geographical proximity to services still comes with a cost and significant access barriers for caregivers of children with ID. And secondly, just to elaborate on that, because it doesn't mean that if like the proximity is closer, and then and therefore the access to the service center is easy. So I think these results, they show definitely that it's very complicated because of the complicated transport system, and that like is not government funded as well. And secondly, poverty and poor infrastructure exacerbate access issues for people living in townships in South Africa. So the majority of South Africans, which are mostly or Black, and mostly they live in very poor conditions, and where like it becomes very difficult for them to even to afford. And we have had over these past few days that like the child support grant has been increased now, because most of these carers that I have interviewed, they are living on child support grant and care dependency grant. So, and all of that money has to be fitted, like in all of these costs. And in some situations, the carers have lost their jobs because there is no one to look after the child with intellectual disability in their home. So they can't afford a person or to employ a person to look after the child. And therefore, they just sacrifice their jobs as well, and then decided to stay at home with their child. And the problem now is that like they are all dependent, and the child on the child support grant, and as well the care dependency grant. And in most cases, the child with ID is not the only child. You'll find in some households there are 3 more other children or 4 more other children, but most of the decisions are made based on the child with ID. And thirdly, public services such as public transport designed for poor people, translated to poor services, as they did in this study, with participants reporting access and experiences of using minibus taxis as difficult. So, unlike in other European states or in elsewhere in the world, where public transport system is functioning very well, but in South Africa, we all still struggle with our public transport system, where like we are all dependent on the minibus taxis, which have like a very difficult safety record, or a very sort of like a weak safety record. And we have seen what has been happening on the roads as well. So these carers, most of them, especially the ones that are on the codes, they are all using like they are all dependent on the minibus taxis. So taken together, these findings show that the challenges with access to care for children with ID and their families go beyond culture and beliefs, and include practical embodied barriers that prevent people from accessing the services they need and want. So in the paper, one of the studies that we have shown is the study that or some studies that have been that are coming out of Africa, that are relying, unfortunately, on the belief systems that like people do not come to the services or to the biomedical services because of their belief systems. I think our study has proven that it's mostly the practical issues that we take for granted that make them that make it difficult for people with intellectual disabilities and their families to access the services. So it's not like they're not coming and accessing the services because they don't believe in biomedical. And I think some of the studies have reported that most South Africans, they practice what is known as pluralism, where like they use both biomedical services as well as like alternative or medicine or indigenous healing methods. So, and even like these participants, they show the desperate need that like we need these services, we need biomedical services for our children. And yet the access to them has proven it very difficult. So I do think that a lot needs to be done in those areas. That will be the end of my presentation. Thank you so much. And these are all my references that I have used in this. So I think we still have some time for the questions, for those who might have questions. Thank you so much.
Dr. Mkabile, thank you so much for that presentation. I think you very eloquently summarized quite a substantive body of work. So we all found that to be very interesting. Yes, so thank you very much. And we would like to open up to questions now, which I'm sure a lot of people will have. If you could just raise your hand perhaps, and then unmute yourself. I can see Anastasia.
Hi, thank you so much. Siyabulela, thank you so much for that presentation. So interesting and so lovely to have you at the Child Guidance Clinic with us. So welcome, lovely to hear you about your work. I was so struck by the important challenge you've posed around the assumptions people make about why people don't access services. And it reminded me of gender-based violence and survivors of gender-based violence who were also understood to not access services because they were ashamed or in some way co-opted or in some sort of codependent relationship. But when research was done, you saw that these women were actually approaching or trying to approach services at least 3 or 4 times and then giving up because they were not getting the help they needed or were not believed or etc. So I just thought it was an interesting correlation between another group of marginalized and oppressed people who are perceived to somehow contribute to their own difficulties because they don't seek help. And in fact, that isn't what's actually happening. It's systemic that people can't access help.
Absolutely, absolutely. Thank you so much for that question, Sia. Yes, that is absolutely true, because we make assumptions that people do not want to come for the services because of their belief systems, because they don't even believe in the biomedical methods. And then, yeah, that is why they're not coming. So those assumptions are sadly generally made. But when we sit and listen to people, to the service users, then they will definitely tell us that these are the reasons why we're not coming, or we find it very difficult or too expensive to come for the service. So, and as I indicated as well, that even contextual, simple contextual, they are not even simple, contextual issues like transport, public transport system that is not functional. So that as well, on top of that, expensive. So it makes it so hard for people to sacrifice the little that they have and come for the services. So I do think that a lot needs to be done, and a lot needs to be to be improved in making the access much easier.
Thank you, Siyabulela.
Thank you.
Thank you, Anastasia. Anybody else? Leslie.
Thank you. Thank you, Siyabulela. Nice to hear you talk. I just want to follow up on what Anastasia said. I think, for us as mental health professionals, we kind of trained to consider the internal world, cultural issues, and all of these sorts of things in thinking about why people do and don't use services. And I mean, it's a much bigger problem than just intellectual disability services. I think many of us have experience of community-based services where we think it's a wonderful idea and then people don't use them. And the thing that really struck me working with Siyabulela is that we overlook the obvious. I mean, if you just think about what it's like to have to spend 40 minutes in a taxi with a child on your lap and face some social issues like stigma, prejudice, and so on, and have to walk where it's dangerous and those sorts of things. I just think it's really opened my eyes to the realities of a life that I don't, as a middle class person who uses private services. I just never think about these things, so I think it's a corrective generally in terms of the way that we think about psychology and our role. So thank you, Siyabulela. Well done.
Thank you, Leslie.
Thank you so much, Prof.
If I could just take this moment, Siyabulela, I've actually had quite it's more of a personal reflection or comment rather than a question. But I've kind of experienced similar barriers to access to health services in my work in the rural south coast of Durban. And I think my main takeaway from your talk today is just how important it is for us as mental health practitioners, as clinical psychologists, to maximize what we do in that session that we have with that person when they eventually do make it to us. You know, with it not being practical to kind of have an elaborate treatment or assessment plan if it takes so much for them just to come for that one session. So when you speak about the disability grants and things like that, just how important it is for us to kind of make the most out of that one session, get things done efficiently for them, just to bear in mind you know, the difficulties in terms of transportation, cost, time. So that was a big takeaway for me. Colleagues, anybody else have anything to say at this point? Yes, I see two hands. Can we have Dane first?
Hi, Sia. Thank you for an amazing presentation. It was quite informative. I just had a question for you. Issues of beliefs, you know, and culture. I know you said that there are all these structural barriers, but my question to you is, where would you then place issues of cultural beliefs? Because I can imagine that although you are emphasizing structural issues, there is still this influence of religion and culture that is quite evident in our society. So I just wanted to know about you. So where do you position issues of beliefs and culture? Thanks, yeah.
Thank you so much, Dane, for the question, and it's good to have you here as well. So the issues of beliefs, South Africa, I've always said that South Africa is a multicultural society, and we cannot do away from from our cultures and the belief systems that we have believed in, or we have used for so many years, for decades, in fact. So, and I think this is one of the reasons why I quoted one of the studies in South Africa. I think it's Pelzer. It's written by Pelzer, where he mentions that we have about 60 or 80-something% of South Africans who are using what he terms pluralism, and that is like they are using both like their biological system or biomedical as well as cultural system, so or indigenous ways of healing. So yeah, there are people who really believe in that like this is what works for them. And I think my argument or our argument in the paper is that it doesn't mean, because that's what like we put when we say why people are not coming for the services or why people are not accessing. We say loosely that it's because of their belief systems, although we sort of like overlook these significant contextual issues. Yeah, people still have their beliefs. There will still be a lot of consultations. There will still be a lot of like searching for answers. and for support, etc. So there is a role like for the belief systems. So I'm not sure whether that answers your question, Dane.
Thank you so much, Sia. That does give clarity. Thank you so much, Sia.
Thank you.
Okay, if we could have Anastasia now.
Thanks. One more from me, Siyabulela, but I suppose this is also drawing on my experience of working in gender-based violence. There's another point about accessing services that I experienced, which is that even when survivors were able to access services against all odds because of structural limitations, the service they received was not what they had hoped to get. And so they didn't follow up with counseling service, for example. And I think that speaks to something about us not actually giving people what they might need. And I know just recently you and I had a conversation about, I was asking you about referring someone with a child with severe challenges on the autism spectrum. And the mom was told that her child was so disruptive and violent that the child would not be accommodated in the public hospital system because they couldn't manage the child. Which is, if you think about it, is absolutely staggering, because then where is that child to go and what is the mother to do? And it spoke to me about a system also that then can't provide what people actually need. And so then they don't go back. I wondered, I don't know if you've done future work on that, or if you've got some comment on people's experiences of the services they do receive and whether they're good enough.
Absolutely. Thank you so much, Sia, for that. Yes, absolutely. I think in one of the papers that we wrote in 2020, we speak a lot about those issues, how difficult it is for the carers to access those services. Even when they are there, they feel a lot of being stigmatized sometimes. And then on the other hand, they also speak a lot of attitudes from health professionals, from us, from ourselves, that, you know, and sometimes we can't even, when when a child or a parent comes to the health center, and then the health professional says that like this person has got intellectual disability, and then attitude is that like we don't know, we're not trained to deal with people with intellectual disabilities. We don't know what to do with them, especially if like they are presenting maybe with underlying psychiatric disorder, or challenging behaviors, or behaviors that challenge, and then that child cannot be attended to because of all of those additional presenting factors. So it's still a very sad situation within, especially intellectual disabilities, because it's the people with ID and their families are still very much stigmatized. And even so, more sad when it happens in a place where you're supposed to be getting help from. So, and that's why most of them, they get stuck and they don't know what to do, and they decide that like, okay, let me keep my child at home rather than like traveling all the way to a health center, and then I don't even get the service that I'm looking for, or I'm turned away because there is no one who knows how to deal with my child. So I fully agree with you. Those are kind of things that still need to be changed in the health system.
Thank you, Siyabulela.
Thank you.
Thank you. Anybody else with questions, just raise your hand and we'll work in that manner. Dane.
Hi, Sia. Sorry, it's me again. I just love your presentation. I mean, I was just wondering, just a question for you. What would you, this issue of distance, as Leslie really emphasized. How would you say that it is possible for these services to be brought closer to these communities? Is that something that can happen, or is it something that is still this distant goal that just doesn't seem to happen? Thanks, Sia.
Thank you so much, Dane. That is a very important question, because as you're speaking, I'm thinking about where we're coming from as the nation, and what have we inherited in terms of like the current health system that we have. So I did indicate as well that the structure of the services, or in particular health services, is based on the past apartheid difficulties that we faced as a nation. So how do we bring them back or closer to the service users who really need? I think one of the things that we need to work on is the public transport system if the services are still far away. I spoke about many ways of doing this in terms of how the services can be designed, can be structured. So if access is one of the things, access has to be made sure that these are as accessible and they are affordable, and people are not struggling to get with the public transport system. So I know there has been quite a lot of improvements in the recent past, as I indicated as well a little bit earlier on, that some mental health services are now situated in district health services, where you will find a psychiatric registrar going there, and then there are intern psychologists that are there as well. So, but as far as intellectual disability is concerned, I think, and compared to what is happening elsewhere in the world, in UK, we are still far behind. So a lot of improvement is still needed to be done to properly service users who have intellectual disability and their families. So firstly, by correcting the public transport issues, and secondly, by making sure that people are able to afford these services, are able to afford going to them and accessing them. So at the moment, that is not happening. So if you ask me, why are the improvements are needed? I think those are the main issues on my side, that let's try to make sure that the services are really accessible, as we mean that they are accessible, and the attitudes of the health professionals within the health centers are completely changed, and not maybe we feel that this is a person with ID and therefore we don't know what to do, about him or her. Therefore, they can go back, or we just easily send them back without any services. Thank you so much, Dan.
Thank you, Dane. I think we have time for perhaps one or maybe two more questions. Colleagues, if there's anybody else that would like to ask something. Okay, I think we've done well for time. Thank you so much, Siyabulela, for a very informative talk. I think we've all found it very engaging. So thank you so much for that. Yeah, I think that is the end of our colloquium today. Thank you.
As well for the invite. Truly appreciate, and thank you so much for everybody who took their time off and come and listen to me. Thank you so much.
Thank you. Thank you, colleagues, for your time as well, and for engaging in discussion and debate. We've all found it lovely. Thank you.